Sleep apnea: why you can sleep all night and still wake up exhausted. Have you ever slept for 7 or 8 hours, opened your eyes in the morning, and felt as if your body had barely slept at all? Maybe your mouth is dry. Your head feels heavy. You need caffeine just to become functional. By afternoon you are fighting to stay alert, and you tell yourself that you are simply busy, stressed, getting older, or just not a morning person. But sometimes the problem is not how long you sleep. It is what happens to your breathing while you are asleep. Obstructive sleep apnea, often shortened to OSA, is a condition in which the upper airway repeatedly narrows or closes during sleep. Airflow drops or stops, oxygen levels may fall, and the brain briefly pulls you toward wakefulness so that breathing can restart. You may not remember any of this in the morning. That is one reason sleep apnea can hide in plain sight. A person can spend 8 hours in bed and still have their sleep broken into tiny fragments over and over again. The clock says they slept. Their brain and body may tell a very different story. To understand why, picture the airway behind your tongue and soft palate as a flexible tube. When you are awake, muscles help keep that tube open. When you fall asleep, those muscles naturally relax. In someone with obstructive sleep apnea, the airway becomes too narrow or collapses repeatedly. The chest may keep trying to pull air in, but little or no air gets through. Eventually, the brain detects the problem and briefly increases alertness. Muscle tone returns, the airway opens, and breathing starts again. Then the person falls more deeply asleep, and the cycle can repeat. Some breathing interruptions are complete. These are called apneas. Others are partial reductions in airflow, called hypopneas. A sleep study can measure how often these events happen and how they affect oxygen levels, heart rate, sleep stages, and other signals. This is different from central sleep apnea. In central sleep apnea, the main problem is not a collapsing upper airway. Instead, the brain temporarily fails to send the normal signals needed to breathe. The two conditions can have different causes and may require different approaches to treatment. For most adults who hear the term sleep apnea, obstructive sleep apnea is the form they are most likely to encounter. So what does it feel like? The most famous symptom is loud snoring. But snoring by itself does not prove that someone has sleep apnea. Many people snore without having OSA, and not everyone with sleep apnea produces the same dramatic snoring pattern. What matters more is the bigger picture. A bed partner may notice that the snoring suddenly goes quiet. There is a pause. Then comes a gasp, snort, choke, or sudden noisy breath as breathing restarts. The person experiencing it may know nothing about it. That is why another person's observation can sometimes be an important clue. But there are daytime clues too. Excessive sleepiness is one of the most important. You may feel unusually sleepy while reading, watching television, sitting in a meeting, riding as a passenger, or driving. And that last situation matters. Untreated sleep apnea can impair alertness and reaction time. If you are repeatedly struggling to stay awake behind the wheel, that is not a symptom to normalize or push through with coffee. Avoid driving when dangerously sleepy and seek medical evaluation. Fatigue can be more subtle than sleepiness. Some people do not describe themselves as someone who could fall asleep anywhere. Instead, they say, "I have no energy, my brain feels slow, or I never wake up refreshed." Morning headaches can occur. So can waking with a dry mouth. Some people wake frequently during the night to urinate. Others notice difficulty concentrating, memory problems, irritability, reduced sexual interest, or a general sense that their thinking is not as sharp as it used to be. Sleep apnea can also look different from the stereotype. The stereotypical picture is a middle-aged man who snores loudly and falls asleep during the day. That picture can be useful, but it can also cause cases to be missed. Women may be more likely to report fatigue, headaches, or insomnia-like symptoms. Someone may complain about poor sleep, mood changes, or exhaustion without ever realizing that breathing is the underlying problem. And body size is important, but it is not the whole story. Obesity is a major risk factor for obstructive sleep apnea because additional tissue around the neck and upper airway can make collapse more likely. But people who are not obese can develop OSA too. Anatomy matters. A relatively narrow airway, a large tongue, large tonsils, certain jaw or facial structures, or simply the way soft tissues are arranged can increase risk. Age matters as well. Sleep apnea can occur at any age, but risk tends to rise as people get older. Family history can matter because airway anatomy and other traits can run in families. Alcohol can make the muscles of the mouth and throat relax further, which can worsen airway obstruction in some people. Smoking can irritate and inflame the upper airway. Certain medical conditions are associated with higher risk, including some hormonal disorders. Heart failure and kidney failure can also contribute through fluid shifts and other mechanisms. And some people notice that their breathing is worse when they sleep on their back. Gravity can allow the tongue and soft tissues to fall backward, narrowing the airway. This helps explain why there is no single sleep apnea person. Two people can have the same diagnosis for very different combinations of reasons. Now think about what repeated obstruction does to the body. Each time the airway closes, oxygen may fall. Carbon dioxide can rise. The nervous system responds to the stress. Heart rate and blood pressure can change. The brain briefly interrupts sleep so breathing can resume. If this happens again and again across the night, the body is repeatedly being pushed out of stable restorative sleep. You may spend enough hours in bed but get less of the continuous sleep architecture your brain needs. That is one reason concentration, memory, mood, and daytime alertness can suffer. But the effects are not limited to how rested you feel. Untreated sleep apnea is associated with important long-term health problems, including high blood pressure and cardiovascular disease. It is also linked with conditions such as atrial fibrillation, heart failure, stroke, metabolic problems, and type 2 diabetes. That does not mean sleep apnea is the only cause of these conditions. Human health is rarely that simple. It means that repeated breathing disruption, low oxygen, fragmented sleep, and the stress responses that come with them can become part of a larger health burden. This is why treating sleep apnea is not simply about stopping an annoying snore. It is about restoring breathing and sleep, improving daytime function, and reducing avoidable health risks. So how do doctors figure out whether sleep apnea is actually the problem? It starts with the story. A healthcare professional may ask about snoring, witnessed breathing pauses, gasping, daytime sleepiness, morning headaches, sleep quality, medications, alcohol use, medical conditions, and family history. They may examine the mouth, throat, jaw, and neck. Sometimes the person sleeping next to you can provide information you simply cannot provide yourself. But symptoms alone usually are not enough to confirm obstructive sleep apnea. The key test is a sleep study. Some people have a full overnight study in a sleep laboratory. This is called polysomnography. Sensors can track breathing, blood oxygen, heart rate, brain waves, eye movements, leg movements, and other signals while you sleep. It sounds technical, but the purpose is simple: to see what your body is doing during sleep rather than guessing from daytime symptoms. For selected adults with suspected obstructive sleep apnea, testing may sometimes be done at home with a smaller set of sensors. Home testing can be convenient, but it is not the right test for everyone. If a person has certain other medical conditions, another possible sleep disorder, or a complicated clinical picture, a sleep specialist may recommend laboratory testing instead. One number you may hear after a sleep study is the apnea-hypopnea index, or I. It describes how often apneas and hypopneas occur per hour of sleep or recording time, depending on the type of test. Doctors use this information together with symptoms, oxygen changes, medical history, and other findings to understand how significant the problem is. This is an important point. A number on a report is useful, but treatment should still be individualized to the person. What happens after diagnosis? For many people, one of the most effective treatments is positive airway pressure, usually called PAP. The best known form is PAP, or continuous positive airway pressure. A PAP machine does not breathe for you in the usual sense. Instead, it delivers a gentle stream of pressurized air through a mask. That pressure acts almost like an invisible air splint, helping prevent the upper airway from collapsing while you sleep. For many people with obstructive sleep apnea, it can dramatically reduce breathing events when it is fitted correctly and used consistently. There are also auto-adjusting PAP machines that can vary pressure and bilevel devices that provide different pressure during inhaling and exhaling. Which system is appropriate depends on the diagnosis and the individual situation. The biggest challenge with PAP is often not whether it can work. It is making it comfortable enough that a person will actually use it. A mask that leaks pressure that feels uncomfortable, nasal congestion, dry mouth, or a sense of claustrophobia can make someone want to give up after the first few nights. But these problems do not always mean PAP has failed. A different mask shape, humidification, pressure adjustments, nasal treatment, or help from a sleep clinic can make a major difference. If you are prescribed PAP and it feels impossible, the most useful next step is usually not to quietly abandon it. Tell the clinical team exactly what is going wrong. Sometimes the solution is surprisingly practical. Not everyone uses PAP. For some people, a custom oral appliance can be an alternative. These devices are usually fitted by a clinician with appropriate dental expertise. A common type gently holds the lower jaw forward during sleep. Moving the jaw can help keep the tongue and surrounding tissues from collapsing backward into the airway. Oral appliances are not interchangeable with a cheap generic mouth guard from a store. The treatment has to fit the person, and follow-up matters. Some patients are candidates for surgical treatment. The goal depends on the anatomy. Surgery may remove enlarged tonsils or excess tissue, reposition parts of the jaw, or address another structure contributing to obstruction. Another option for selected patients is hypoglossal nerve stimulation. This involves an implanted device that stimulates a nerve controlling tongue movement so the airway is less likely to collapse during sleep. It is not appropriate for everyone, but it shows how treatment has moved far beyond a one-size-fits-all approach. And there has been another important development. In the United States, the FDA has approved tirzepatide for the treatment of moderate to severe obstructive sleep apnea in adults with obesity alongside reduced calorie eating and increased physical activity. This was the first medication specifically approved by the FDA for obstructive sleep apnea. That does not mean sleep apnea can now simply be treated with an injection instead of evaluating the airway. The approval applies to a specific group of patients, and tirzepatide is a prescription medicine with potential risks, side effects, and contraindications that need to be discussed with a healthcare professional. For people with obesity, weight reduction can improve the mechanics of the upper airway and reduce the severity of OSA. The medication is one possible tool within that broader treatment strategy for eligible patients. It should not be started, stopped, or substituted for prescribed PAP therapy without medical guidance. Lifestyle changes can also matter, but they need to be described realistically. If excess weight contributes to a person's sleep apnea, weight loss may reduce severity. Regular physical activity supports overall health and weight management. Limiting alcohol, especially near bedtime, may help because alcohol can promote upper airway relaxation. Quitting smoking is beneficial for overall health and may reduce airway irritation. And for some people whose sleep apnea is strongly position dependent, sleeping on the side rather than the back may reduce obstruction. But lifestyle changes should not become a reason to postpone diagnosis. If someone has moderate or severe sleep apnea, telling them simply to lose weight and sleep on your side may be nowhere near enough. Treatment should match the severity and the cause. There is also a psychological side to getting this diagnosis. Some people feel embarrassed by snoring. Others dislike the idea of wearing a mask at night. Some think using PAP means they have failed to take care of themselves. None of that is medically useful. A breathing device is just a tool. Glasses help eyes focus. Hearing aids help hearing. An inhaler helps certain lungs move air more effectively. PAP helps keep an airway open during sleep. The goal is not to win an argument with the machine. The goal is to breathe and sleep better. There is another reason not to ignore symptoms. Sleep apnea can affect daily safety. If you are so sleepy that you are nodding off while driving, operating machinery, or doing work where a moment of inattention could injure you or someone else, take that seriously. Do not rely on loud music, an open window, or caffeine to make dangerous drowsiness safe. Stop the risky activity and seek medical evaluation. And when is the situation an emergency? Typical obstructive sleep apnea causes repeated short breathing interruptions during sleep, and the person usually restarts breathing. But if someone is not breathing normally, cannot be awakened, becomes blue or gray, has a seizure, collapses, or appears to be in severe respiratory distress, do not assume this is just sleep apnea. Call your local emergency service immediately. Likewise, new severe chest pain, signs of a stroke such as sudden facial drooping, arm weakness, or difficulty speaking, or severe shortness of breath need urgent emergency assessment. Sleep apnea may increase the risk of cardiovascular problems, but an emergency symptom needs to be treated as an emergency, not explained away by a known sleep diagnosis. There are also non-emergency situations that deserve a timely appointment. If your partner repeatedly sees you stop breathing in sleep, if you wake gasping, if you snore heavily and are persistently exhausted during the day, or if your sleepiness is interfering with work, concentration, or safe driving, talk with a healthcare professional. The same is true if you have difficult to control high blood pressure and symptoms suggesting sleep apnea. You do not need to diagnose yourself first. In fact, you should not. Fatigue can come from many different causes, including anemia, thyroid problems, depression, medication effects, insomnia, chronic pain, and many other conditions. Morning headaches have many causes. Frequent nighttime urination has many causes. Even snoring has many causes. The pattern is what matters, and proper testing helps separate sleep apnea from other explanations. If you have already been diagnosed, follow-up is part of treatment. Bodies change. Weight can change. Medications change. Medical conditions change. Masks wear out. Dental appliances may need adjustment. A treatment that worked well several years ago may need to be reassessed. If symptoms return, if the device becomes difficult to use, or if your weight changes substantially, your clinician may recommend reviewing treatment or repeating testing. And if PAP is prescribed, consistency matters. Using it only on the nights when you feel especially tired does not address what happens on the other nights. Sleep apnea does not check the calendar before the airway collapses. The same applies to naps for people who have been advised to use PAP whenever they sleep. One of the most encouraging things about obstructive sleep apnea is that it is treatable. The right treatment varies, but the condition is not something you simply have to accept as part of aging. A person who has spent years waking unrefreshed may discover that their normal was never actually normal. The change is not always dramatic on the first night. Some people notice improvement quickly. Others need time to adapt to therapy or to address several factors at once. But understanding the cause transforms the problem. Instead of fighting fatigue with more caffeine, blaming yourself for low energy, or assuming that loud snoring is just an irritating habit, you can ask a much more useful question. Am I breathing normally while I sleep? That question is especially worth asking when the clues line up: loud, habitual snoring, witnessed pauses in breathing, gasping at night, unrefreshing sleep, morning headaches, and persistent daytime sleepiness. Not every tired person has sleep apnea. Not every person who snores has sleep apnea. But when breathing repeatedly stops during sleep, the body is doing real work at a time when it is supposed to be recovering. Good sleep is not simply unconsciousness for 8 hours. It is a coordinated biological process in which breathing, oxygen, brain activity, heart function, and sleep stages move through the night without constant interruption. Obstructive sleep apnea disrupts that process. And because the interruptions happen while you are asleep, recognizing the problem often begins with clues rather than memories. A partner hears the pauses. A driver notices frightening sleepiness. A patient realizes that 8 hours in bed never feels restorative. A doctor sees difficult to control blood pressure and asks about snoring. A sleep study finally connects the dots. If that sounds familiar, the next step is not to panic, and it is not to buy a random device online. It is to discuss the pattern with a qualified healthcare professional and, when appropriate, have it properly tested. Treatment may involve PAP. It may involve a custom oral appliance. It may involve weight management, positional strategies, surgery, nerve stimulation, medication for eligible patients, or a combination of approaches. The important part is that the plan is based on your diagnosis, your anatomy, your health conditions, and the severity of your sleep apnea. This information is for general education and cannot tell you whether you personally have sleep apnea or which treatment is right for you. But it can give you a reason to pay attention to a symptom that is easy to dismiss. Sometimes feeling exhausted after a full night in bed is not a problem of motivation. Sometimes the night has been full of interruptions you never remember. And sometimes the path to better mornings begins with something as basic and as important as breathing freely while you sleep.